Good morning, this is Annette Rebel with your ITE Keyword Review for 2019, topic area Hematology. Somehow I always have the pleasure of doing Monday mornings, so I hope you are all coffee and loaded and ready to go. So these are the keywords from 2018, and as you guys are all aware, this exam loves repetition and redundancy. There will be a lot of repeated questions from last year. So I really encourage you to review also my podcast from 2018, where I covered all those keywords, because I do believe you will find also some repeat questions in this year's exam. Today's podcast, I will focus on the new or emphasized keywords for this upcoming exam 2019 that was new last year. And the ones are highlighted here in yellow. But so to kickstart things off, let's start with oxygen transport and the principles of hemodynamics and oxygen delivery. Oxygen delivery depends on your cardiac output and your arterial oxygen content. The formulas are shown here in the slide. So as with acute blood loss and anemia, a very common disturbance we see in the operating room, a decrease in hemoglobin concentration, will be compensated by an increase in cardiac output. Cardiac output depends on stroke volume and heart rate. So in a healthy, cardiac function unimpaired patient, you would expect that first the stroke volume increases and then the heart rate to compensate for decreases in arterial oxygen content. That's the compensation of acute anemia. So for blood component therapy, and specifically for blood transfusion, what's our indication, our transfusion threshold? The global answer to this question is when you identify that your oxygen delivery does not meet your demands, your oxygen consumption, due to either limitation in cardiac output or exhaustion of cardiac output increase. As a rough guidelines, we think we're reaching transfusion threshold with the hemoglobin concentration is equal or less than 7 grams per deciliter. 7 milligrams per deciliter. That also would be equivalent to a hematocrit of 21%. Or if you find other indication for insufficient oxygen delivery, as it could be mental status changes, EKG changes, or indication for anaerobic metabolism, as it will be the metabolic acidosis, increase in lactate production, a decrease in mixed venous saturation. So what are the indications for giving packed red blood cells? Exactly what I've stated in the previous slide. DO2 doesn't meet VO2, hemoglobin level less than 7 milligrams, sorry the slide is incorrect here, 7 milligrams per deciliter, or indications, either clinical or laboratory for insufficient oxygen delivery. One of the keywords for me to cover was PRBC additives. So the packed red blood cell unit has following characteristics. Volume is around like 300 cc's, and the iron content for each unit is about 200 milligrams per unit. Hematocrit concentration can vary between 55 to 70% depending on what kind of preservative we use. So what kind of preservatives are used in packed red blood cells, and what is their impact on shelf life? And then we're also going to talk about whole blood. So the anticoagulants used in packed red blood cells, there are two different types, and the impact varies on shelf life. The basic one is citrate, phosphate, and dextrose. If you use that primarily for preservation, you have a storage time around 21 days. If now adenine is added as a source of ATP, it makes then the CPDA preservative, also the most common one, gives you a storage time up to 35 days. Addition of AS1, AS3, or AS5, the most common one here is adsole. We're adding more dextrose, more adenine, and so therefore we can increase the storage time up to 42 days. One completely different way how to preserve packed red blood cells is by freezing them. The preservation here by adding glycerol, it allows to store those packed red blood cells at -65 to -120 degrees Celsius, and we can keep them at this temperature for up to 10 years. So rare blood types or our crisis, catastrophe storage, that's how you preserve red blood cells like that and ensure you have enough. But before you can use them, there are several steps you have to go through to get rid of that antifreeze. Okay, first, the units have to be thawed. Lasts about shortest 30 minutes depending on how what temperature environment you use. And then after thawing, you need to wash off that glycerol using various concentrations of sodium chloride and dextrose, and that washing process needs several hours. After that washing, you can keep those units at 1 to 6 degrees Celsius, but you have to use that product here within 24 hours, otherwise you encounter significant hemolysis. The final hematocrit is around 70 to 80%, so higher than in a regular PRBC. Since there's a lot of loss in red blood cells in just due to the mechanical washing, your yield, the volume of that unit is less than in a regular packed red blood cell. You really only want to thaw them if you anticipate a high probability of using this unit. However, if you do not use that unit, it can be refrozen, but the volume surely, if you go through several times, and the mechanical durability of those red blood cells will be suffering. Okay, so what is different if we have access to whole blood? Whole blood, the unit has a higher volume. It's about 500 cc's, doesn't go through a concentration process. Still contains some preservatives, as I said, the citrate phosphate dextrase and plus minus adenine as anticoagulant. The shelf life for whole blood is between 12 to 21 days. However, you get the best results if you use whole blood within 24 hours after donation. When I say best result, it focuses on that your platelet activity and your activity of factor 5 and factor 8 are significantly decreased after 24 hours. The other coagulation factors still sufficient up to 12 days after donation. But that's why the rationale is to use whole blood as early as possible, best within 24 hours after donation. And you still may reprocess this blood component with leukofiltration. We'll talk about this in the next slide. So let's touch on massive transfusion. It's defined when I use more than 10 units of packed red blood cells, or have to transfuse more than 1 blood volume, or if I give more than 1 unit in less than 5 minutes as a continuous process. And there are certain complications which we will go through associated with this high volume blood component therapy. Massive transfusion complications. Number 1, the citrate toxicity. Citrate is added as an anticoagulant, and it works by capturing the calcium. So therefore, if I give a lot of citrate fast, then we get symptomatic hypocalcemia because it captures your plasma calcium. The symptoms of hypocalcemia is prolongation in your QT interval, hypotension, and a narrow pulse pressure. The risk for citrate intoxication is increased in pediatric patient, liver disease, and in a hypothermic patient. Massive transfusion itself can cause hypothermia, as some of you may have encountered in trauma patients. You don't have enough time to warm up the blood components you're transfusing through your warmer to get it up to body temperature. So in combination with exposure in high volume resuscitation, it easily drops your core temperature below 34, 33 degrees, and that's significant hypothermia, so therefore slowing down your enzymatic activity. Other complications of massive transfusion are in acid-base abnormalities, the metabolic acidosis, but also we see alkalosis, since citrate gets metabolized to bicarb by a competent liver. In the electrolyte abnormalities, what we fear most is hyperkalemia. However, we much more commonly encounter hypokalemia due to a catecholamine-driven potassium shift inside of the cell. And shifts in magnesium level, hypomagnesemia, has been described. Now let's quickly review transfusion reactions. The structure I use here when I talk about transfusion reactions, they are transfusion reactions related to red blood cells, but also to leukocytes. The ones we focus on will be the leukocyte-mediated one, and so one easy step to reduce your transfusion reactions to white blood cell contamination is by reducing the white blood cell contamination. The step is called leukoreduction, and from a very high concentration of white blood cells in a regular donated unit, with that step you decrease into less than 5 millions per unit, so a significant reduction. And it's just an additional filtration process which added after blood donation. But this step may be very helpful in reducing significant transfusion reactions, most importantly the febrile non-hemolytic transfusion reaction, but also CMV, the HLA autoimmunization, meaning patients making antibodies against HLA-based antigen, and also reduces the immune modulation caused by blood component therapy. So think about a graft versus host reaction or post-operative infection. The one keyword I want to focus on is the febrile non-hemolytic transfusion reaction, the most commonly seen transfusion reaction. It's defined by an increase of more than 1 degree Celsius in association with a blood transfusion in absence of any other identifiable cause. So you think about, like, it should be a septic reaction, shouldn't be an acute hemolytic transfusion reaction. So you rule all that out. Patients still have an increase in temperature, so therefore most likely will be a febrile non-hemolytic transfusion reaction. And it's caused actually by the recipient's response, that the recipient has antibodies against HLA-based antigen, which has been found on the leukocytes. So therefore, it's logic that leukocyte reduction may decrease the severity and frequency of this transfusion reaction. Well, the way how it's seen or it's coming across is by usually occurs 45 minutes after transfusion start and lasts about 1 to 2 hours. The reaction is fairly benign, but in a already sick and anemic patient may still be causing significant symptoms. The workup for this transfusion reaction is first to stop the transfusion and rule out all other causes. However, if you have made sure it's not septic, it's not a hemolytic transfusion reaction, you can treat this with antipyretics, acetaminophen, meperidine, to minimize the impact. So now let's move on to coagulation-based keywords. The thromboelastogram, or also called TAG, was a pretty well explored area in previous in-training exams. So when you look at the TAG, you characterize the TAG by those different numbers. The R value, the K value also can be expressed as the alpha angle, then maximum amplitude, and then maximum amplitude after 30 minutes. And information you get is like the R value is the reaction time, is the time to when the clot starts forming. So it tells you a little bit about like how many coagulation factors are in there and how willingly are they interacting with each other. The K value, or the alpha angle, tells you about the expediteness, the speed of the clot development, and how well the coagulation factors, fibrinogen, and platelets interact with each other. The maximum amplitude is a measurement of clot strength. So therefore it gives you information about the platelet quantity and quality and the strength of your fibrin clot. And if you review the maximum amplitude after 30 minutes, it tells you how mechanically durable the clot has been, which has been formed. Okay, so let's look at a few graphs here about the different tag formations. The normal one is here on your left side. And then if you look at those examples, there's the hypercoagulable state, then the hypocoagulable state with fibrinolysis, to give you an idea how those tags may look like and what information you get. But let's give you some examples like how we see this here at our computer screen at the University of Kentucky. So the clot, this is like a normal tag as you would see it on the computer. So here's the R time. Okay, this interval tells you when the clot starts forming. Then the K value, or the alpha angle, this is this steepness here at the first line. How far has the clot developed to meet a certain threshold? Here normal is 1 to 3. So this is a completely normal looking tag. The alpha angle also is completely normal. The steepness of this clot development tells you about the clot formation, the interaction of coagulation factors, fibrin, and platelets. And then here the maximum amplitude over here tells you about the clot formation, the platelet quantity, quality, and then as we look at further on, the clot durability, how stable it is during mechanical stress. So here in B and C we have some obviously different looking tags with some pathology. Here in tag B, this is your R time. Okay, and if you look at the number, what's normal, only compared with your normal tag, this is prolonged. Okay, so the K value is abnormal. Your maximum amplitude is decreased. So this is a lack of coagulation factors, also expressed here in the alpha angle in the K time. And then with maximum amplitude also reduced, it probably also is a lack of platelets, and plus minus probably also fibrinogen. So a complex coagulopathy, but this is here where the tag tells you what you need to be doing. Okay, you need to replace coagulation factors and probably platelets and plus minus also fibrinogen. FFP does contain fibrinogen, so just here with giving FFP and a platelet concentrate, you may be able to address the displayed coagulopathy. Here in C, you see a much more complex coagulation disorder. Still your R time, not normal. Okay, your alpha angle, in the beginning okay, but what's definitely completely out of range is your clot formation and durability. So a lot of fibrinolysis, your clot is not mechanically durable. So probably lack of coagulation factors, but lack of platelets, lack of fibrinogen, and lack of clot durability were the interpretation of this tag. All right, let's talk about clot durability and fibrinolysis here on those exams. And again, your normal tag. And now if you look at B and C, okay, they also have significant signs of fibrinolysis. You can also call this here the fishtail. Okay. You look at this tag, kind of like still okay. You know what we see here, but what's here, this is not mechanical durable. So therefore, signs of fibrinolysis in these both patients would benefit not only from replacing of some coagulation factors, but also you have to stop the consumptive coagulopathy. So this is TAG for you. So let's talk about some inherited or acquired coagulopathy. The one always emphasized in in-training exam is hemophilia, hemophilia A versus B, and von Willebrand disease. Hemophilia A is the lack of factor 8. Hemophilia B is the lack of factor 9. Coagulation profile looks relatively normal except an increase in PTT. Hemophilia is X-linked recessive, so therefore females are only carriers. Treatment for hemophilia A, desmopressin, because it releases the endothelial factor 8. If that doesn't work, factor 8 concentrate. Okay. Novo-7, that was actually the first FDA-approved indication for Novo-7, was a bleeding, uncontrolled bleeding in a hemophiliac patient. Okay. And Novo-7 actually treats hemophilia A and hemophilia B. Hemophilia A, if you have a patient like that, you may want to get a hematology consult, because depending on what kind of procedure you are planning and what kind of factor activity your patient has, that may define the treatment. Von Willebrand disease looks, laboratory-wise, relatively similar to hemophilia, but it's a different deficiency. So normal coagulation profile except elevated PTT. Okay. Here the pathway, the inheritance pathway, is autosomal dominant, so therefore men and women. And there are different types depending on what kind of von Willebrand deficiency or abnormality you have. Majority of von Willebrand patients have type 1, okay, which also means you only have a decreased factor activity. Type 2 and type 3, from abnormal looking von Willebrand factor to complete absence of von Willebrand factor, that here is the difference in what type you have. Von Willebrand factor, von Willebrand disease also can be acquired when you have an autoimmune disease. If you make autoantibodies, you can also develop this. The treatment for von Willebrand disease is desmopressin, 0.3 micrograms per kilo, because that also facilitates the endothelial release of von Willebrand factor. Obviously, not every type of von Willebrand disease will respond to that. There are von Willebrand factor concentrates. Platelet concentrates also contain von Willebrand factor if you have poor response to the steps above. And in extreme situations, also cryoparticipants, can help with controlling this coagulation abnormality. Another keyword to address are indications for FFP. Well, what's in FFP? Okay. Pretty much all the coagulation factors except 8. Okay. But also it contains antithrombin. It also contains protein S and protein C. So FFP is indicated for coagulation factor abnormalities if either you don't have an appropriate product or if it's multiple factor deficiencies, as you would see with DIC. Reversal of warfarin is a vitamin K antagonist, therefore reducing the production of vitamin K dependent coagulation factors. In MTP, FFP is an equal volume component of massive transfusion protocols. And the antithrombin 3, that's probably an important one to point out, is if you have a heparin resistant patient, then antithrombin 3 can facilitate your heparin activity by providing that. Please keep in mind that FFP also contains fibrinogen, like in the range of 180 to 400 milligrams, depending on your donor concentration. That is equal to plasma, but not as much as cryoparticipant. What are FFP contraindications? Do not use it for volume expansion. FFP contains citrate, so therefore it has an anticoagulant on board. The INR of FFP alone is 1.7 or so, so therefore it's going to be difficult to correct an INR of less than 1.8 with FFP. If a patient is not coagulopathic, it's probably not indicated. And surely if you have a more specific product for a single factor deficiency available, FFP would be overshooting the target. If you have a patient on warfarin who is coagulopathic, when you have time for correction, you also may be better off with correcting with vitamin K than using FFP. To reverse an INR or coagulation with high INR with FFP, the concentration you would use is 10 to 15 cc's per kilo to reverse that INR elevation. So in a 70 kilo patient, that would give you 700 to 1 liter of plasma you have to transfuse to reverse an INR. That's a significant volume to give a patient. So therefore, as an elegant option to reverse coumadin overdose or coagulopathy due to factor deficiency, those vitamin K dependent factors, is the prothrombin concentrates or PRBCS. The factor 4 has K-Central, that's what we use here at UK, has all 4 coagulation factors needed to reverse coumadin-induced coagulopathy. If you use FIBA, that has activated factor 7, so he even go one step further. And here you give about 10 to 20 units per patient, and that comes down to a volume of 100 to 150 cc's to completely reverse your INR elevation. Therefore, much faster because you just give a lot smaller volume, so therefore get this on board faster. Last not least, keyword to review is the low molecular weight heparin. The mode of action. For all heparins, the mode of action is it's a catalyzation of antithrombin 3, which does inhibit your thrombin, your factor 2A, and also the other coagulation factors, which is 9A, 10A, 11A, and 12A. By inhibiting those factors, you prevent the fibrin formation and the thrombin-induced platelet activation. So therefore, that's how you block your coagulation cascade. The difference between the unfractionated heparin and the low molecular weight heparin is that due to a clinical modification, either polymerization or enzymatically, you have a smaller fragment, and so therefore you have less inhibitory action on thrombin, and your activity is more geared towards factor 10A. This gives you a much more predictable pharmacokinetic. The advantage is that you have a stable dosing, 1 or 2 injections a day, and there's no need for specific laboratory monitoring. If you would, it would be factor 10A and not PTT. So what are the adverse side effects to consider with heparin therapy? And here I'm going to point out what's different between unfractionated heparin and low molecular weight heparin. So all heparin, your anticoagulated patient, number 1 complication is going to be bleeding. But what we worry about in a lot of patients on heparin therapy, this is heparin-induced thrombocytopenia, also called HIT. It occurs in 5% of patients receiving the unfractionated heparin, but it's much less common in low molecular weight heparin therapy. This complication occurs between 5 to 10 days after therapy start because we have to develop antibodies against this platelet 4 factor. Unless you had previous heparin exposure, and it also can start earlier. And the complication we worry about, not necessarily the thrombocytopenia, although we worry about that, but we have thrombocytopenia because we have massive clot formation in arterial and venous circulation. So a lot of patients die because of thrombosis, DVTs, arterial occlusions, or PEs, in addition to then the bleeding due to thrombocytopenia. So other heparin side effects is osteoporosis, also here much more common with chronic high-dose unfractionated heparin therapy. Hyperkalemia has been described, and it's secondary to the aldosterone suppression caused by heparin. And then also your liver function tests, the AST, the ALT can be elevated, but without any evidence of liver dysfunction. So I hope this review highlighted a few areas which the ITE will explore. I'm looking forward to talk more to you about this, and good luck with the test.